Hello, everyone, and welcome to today's webinar, Diabetes and the Clinical Laboratory. I'm Jennifer Woods of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott Diagnostics. To learn more, visit abbott.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Professor W. Garry John, consultant in clinical biochemistry, Norfolk and Norwich University Hospital. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. John, you may now begin your presentation.
Jennifer, thank you for that nice introduction. Ladies and gentlemen, I'm going to talk today about diabetes and the clinical laboratory. So let's first look at diabetes. Diabetes has been with us for many, many years. Indeed, we can look at this papyrus from ancient Egypt dating back to 1500 BC, where the text described the classic symptoms of polyuria seen with diabetes. Coming forward to the 1600s, a biochemist and physician called Willis described the urine of diabetics as having a sweet taste. And of course, he knew that he was a biochemist because he associated this with guzzling down of wine. But urine became a very important part in identifying diabetics for many, many years. But what is diabetes? Well, in 1980, the WHO Expert Committee on Diabetes described it as a state of chronic hyperglycemia, a very broad description. In 1997, this was further refined by the ADA Expert Committee as a group of metabolic diseases characterized by hyperglycemia, resulting from defects in insulin secretion, insulin action, or both. And overall, this description is still widely used today. But what is hyperglycemia? There are a number of variables that affect the glucose concentration. The population in which we are looking, different populations have different reference ranges for glucose. Fasting and feeding have an effect on the glucose result, as does age, sample type, and analytical method. So we need to ask ourselves, what is hyperglycemia? And we may come back to that a little later on. So diabetes, there are a number of different types of diabetes. Let's look at them individually. Type 1 diabetes mellitus. This is due to an autoimmune destruction of the beta cells of the islets of Langerhans. This results in insulin deficiency and eventually a lifelong dependence on insulin injections. This is due to the beta cell destruction, which is a slow and progressive process, taking several years to finally complete. Whereas the clinical onset of diabetes is abrupt, usually measured in weeks. So you get this destruction happening for a long time, and then suddenly the individual becomes diabetic. And in many cases, the first sign is actual presentation into A&E with ketoacidosis and hyperglycemia. There are a number of markers of developing type 1 diabetes. the appearance of glutamic acid decarboxylase, cell autoantibodies, and insulin autoantibodies. And these can be detected 10 to 15 years before the onset of the disease itself. But it's worth noting that not everybody who has these autoantibodies go on to develop type 1 diabetes, although the chances increase the more of the autoantibodies you actually have. Unlike type 1 diabetes, type 2 diabetes has an etiology which is unknown. It is a defect in insulin secretion and or insulin action. And the disease itself is likely to be polygenic. It is a group of disorders that is characterized by the development of hyperglycemia. The vast majority of patients have some degree of insulin resistance, but insulin resistance itself does not cause type 2 diabetes, which only manifests if there's a coexistence of insulin secretory defect. Now, type 2 diabetes is the most common form of diabetes. Around 90% of all diabetic cases are type 2 diabetes. And it is the most common non-communicable disease in the world. It is predicted that over half the patients will live in Asia. Type 2 diabetes is commonly found in the older individual, adults, but unfortunately is increasingly being seen in children, adolescents, and younger adults. This is due to the rise of level of obesity, the decrease in physical activity, and poor diet found in these younger individuals. You can see here the relationship between obesity and type 2 diabetes. We can see that as body mass index increases, so does the rate of type 2 diabetes, both in women and in men. So you can see straight away that obesity is directly related to the development of diabetes. If we look at the picture of diabetes around the world, in 2000, the global estimate of adults living with diabetes was 151 million people, a big number in its own right. And it was predicted in 2010 that the global projection for diabetes by 2025 would be 438 million. Now in 2020, with 5 years still to go, that prediction has been surpassed by 25 million individuals. Today, we calculate 463 million people are living with diabetes. 9.3% of the adult population between the age of 20 and 79 years of age. And a further 1.1 million under 20 living with type 1 diabetes. The IDF estimates, the International Diabetes Federation estimates, there will be 578 million adults with diabetes by 2030, and an unbelievable 700 million by 2045. Numbers you can hardly believe can exist. The next type of diabetes, of course, is gestational diabetes, and this occurs during pregnancy. Gestational diabetes is hyperglycemia during pregnancy, with blood glucose values above what is normally found, but below those diagnostic of diabetes. Women with gestational diabetes are at increased risks of complications during pregnancy and also mainly at delivery. Then these women, and possibly the children, are also at increased risk of developing type 2 diabetes in the future. There are a number of other types of diabetes described by the WHO, but probably the most interesting one here is maturity onset diabetes of the young. This is an increasing disease population, as more and more people who we thought as young individuals with type 1 are actually MODY, the maturity onset non-insulin diabetics. So let's look here. This is young Leonard Thompson, who at 14 years of age was the first patient to receive insulin on January 11th, 1922. At this point in time, he had a very, very high blood glucose and was urinating about 5 litres a day. He was only kept alive on a low-calorie diet with low carbohydrates, because before this time, we had no means of treating our patients with type 1 diabetes, and they would die at a very early age. Luckily, 2 Canadians, Charles Best and Frederick Banting, discovered the use of insulin and actually used insulin to treat a diabetic dog. Now, we remember Best and Banting, but who remembers the dog? What was the dog's name? Well, this most important person was called Marjorie. Remember that. Best, Banting, and Marjorie. So this is young Leonard Thompson, 12 months after first treated with insulin. We can now see that he is a well individual, slightly overweight maybe, and that was a new challenge we had. The new challenge was how to control the glycemia in our patients with diabetes and prevent the complications associated with long-term hyperglycemia. This is where the clinical laboratory comes into the story. And for many years, dating back as far as the 1900s, the only thing we had to offer was glucose. We could measure glucose, ranging from very early tests for glucose to present-day enzymatic methods. But we've seen this slide already. What is hyperglycemia when measured using glucose? There's a whole range of different things affect the glucose value. Even samples collected will lose glucose concentration from them after collecting from the arm. Glucose concentrations are lost from the glucose sample, even if we use an anticoagulant with a material to stop the glucose being lost. Fluid oxalate is commonly used. You can see here in this slide that even with fluid oxalate in the sample, over the course of the first 1 to 1.5 hours following collection, glucose concentrations are lost from the sample at about the same rate as if no glucose blocker was actually used. After about 1.5 hours, the glucose loss is stopped, whereas if there's no glucose blocker, then it actually carries on. We can see here, glucose results in our samples are dependent on what the collection material is and length of time after collection. So using glucose to assess glycemia was a problem. We needed something new. Luckily, in 1968, a researcher called Rabat, who was looking at the red cells from patients with diabetes, described what he called as an abnormal fast-moving hemoglobin. We now know, of course, this abnormal hemoglobin is not abnormal, but is glycated hemoglobin. But what is glycated hemoglobin? Well, you may have seen some slides showing the formation of glycated hemoglobin, but it's not quite as straightforward as that. Let's go through this slowly. Glucose, as long as it's in the open chain format, will react with all proteins in the body. The glucose will bind preferentially in most proteins to the lysine residue. Hemoglobin is unique in that the glucose in the hemoglobin molecule binds to the N-terminal valine. But note only if the glucose is in the open chain format. If it is in the ring structure, it does not react. Glucose binds in this readily reversible reaction, forming a Schiff base or aldamine. This Schiff base will then undergo an almost irreversible Amendouri rearrangement, where the double bond moves from position number 1 to position number 2, thereby stabilizing this fraction. Again, if the ring forms of glucose happens, the reaction does not happen itself. So the overall reaction takes place in 2 stages. The first is a readily reversible reaction, which takes place over a number of hours, and thereby reflecting a hour-by-hour change in the glycemia in the body. The second, almost irreversible reaction, and for all intents and purposes, we can assume this is non-reversible, takes place over several days. So the glucose levels have to be at a certain concentration to create this final ketoamine, or hemoglobin A1c, or glycated hemoglobin. The entire reaction follows the law of mass action. It's a non-enzymatic reaction, which actually means the more of the reactants there are, the more of the product is formed. So in a hemoglobin molecule, this takes place over the lifespan of the red cell. And once this glycated hemoglobin is formed, it remains in place for the life of that red cell. So what period of time are we looking at? It is thought that the glycated hemoglobin A1c, reflects the previous 3 to 4 months of glycemia within the body. Well, that is true. But overall, when we look at the results, the sample that we collect reflects glycemia in the month in which that sample is collected. 52% of the result in that hemoglobin A1c is based on the month in which the sample is collected. Only 27% of the effect of that result is from the month before, 14% for the month before that, and only about 6% reflecting glycemia 4 months before the sample. So yes, overall, hemoglobin A1c does reflect glycemia over the preceding 3 to 4 months, but the vast majority of the effect on that result is within the month of the sample being collected. So we have hemoglobin A1c. So how are we going to measure it? Well, there are a number of method principles we can use to measure hemoglobin A1c. If hemoglobin is glycated at the N-terminal valine, and only at the N-terminal valine, what I forgot to say, it will glycate at other parts of the hemoglobin molecule. If it glycates at the N-terminal valine, it creates a very small charge difference. Of course, it creates a structural difference and also a chemical difference. So let's look at charge differences. Probably the most recognizable method by which you measure hemoglobin A1c is cation exchange HPLC. And there are a number of manufacturers worldwide now that will sell you HPLC for cation separation. Charge separation is also achieved using capillary electrophoresis. This is a slower method, but creates a greater separation in the peaks that you see of hemoglobin A1 and hemoglobin A0. To achieve this throughput required, these capillaries are run in parallel, several at a time. Structural differences. Affinity chromatography. We can use boronic acid here to bind the glucose moiety of the hemoglobin, glycated hemoglobin. It recognizes the cis diols on the glucose attached to the protein. So this now measures all glycated hemoglobins. Hemoglobin glycated at the N-terminal valine and hemoglobin glycated at lysine residues. The glycated hemoglobin binds the boronic acid and the non-glycated hemoglobin washes off the column. We can then use a counterligand to wash off the glycated hemoglobin, and we can measure the color in the two fractions and calculate a percentage. Immunoassay. You can imagine how difficult it was to raise antibodies against glycated hemoglobin, where the main difference is the glucose moiety. Nowadays, there are a number of immunoassays available which recognize 3 or 4 amino acids and the glucose attached to the N-terminal valine. Chemical differences. This is the newest method available on the market, and this uses an enzymatic method to recognize a dipeptide with glucose attached to it, and converting that fructose dipeptide to H2O2 and measure it colorimetrically. This method can be used on an automated analyzer within the laboratory. All methods are actually extremely good and provide a good outcome, and it would be up to the laboratory which method they choose. But if you're going to choose a method, then the thing we need to consider is standardization. Let's look back to when these methods were first described back in the early 70s and early 80s. Things didn't look good for fashion back in those days, but things look even worse for hemoglobin A1c. This here shows that between laboratory agreement for hemoglobin A1c in a large region within the UK. And we can see between laboratory CVs about 30%. What does that mean in reality? Well, it means if you went to one laboratory and had your blood sample measured for hemoglobin A1c, you could get a result of 4.3%. If you had the same blood sample measured in another laboratory, you could get a result of 9.4%. This resulted in an almost unusable method for diabetic control. No standardization. We can see the same thing in the College of American Pathologists CAP scheme, where in 1993, results could vary between 7.5% down to 2.5% on the same EQA sample. No standardization. This lack of standardization led to a number of countries introducing national standardization schemes. Probably the most recognized one is a National Glycohemoglobin Standardization Program, now called the NGSP. The problem with all these national schemes was there was a lack of a true reference method. There was no primary reference material and no traceability. But these harmonization schemes did work. And when we look at the CAP scheme of the 1990s and early 2000s, we can see an improvement in the target values being achieved by different laboratories. And this was a result of harmonization of these results. But the IFCC recognized that there's a need for global standardization of hemoglobin A1c. If we were to use this value nationally, internationally, to set targets for individuals. So a working group was set up with members from North America, from Europe, from Asia, and from Australia. It was my great pleasure to chair this working group. And over the time period, we actually developed a reference method based on metrological requirements. Metrological requirements require you to identify the measurand, what you are going to measure. Reference measurement procedures, reference laboratories, reference materials, and traceability. So let's look at the measurand. We decided that we would measure hemoglobin that is glycated at the N-terminal valine. We would not include hemoglobin that was glycated at other parts of the molecule. And the IFCC committee on naming these compounds, named it hemoglobin beta chain blood N 1-deoxyfructosyl 1-yl hemoglobin beta chain. A mouthful, you'll agree, but you can call it hemoglobin A1c. Also, at the metrological conditions, we should report in SI units. So the SI unit for hemoglobin A1c is millimole per mole. That is millimole of hemoglobin A1c per mole of hemoglobin A0 plus hemoglobin A1c, the two fractions that you can measure. A reference measurement procedure. Before you have a reference method, you need to have standards. So the first thing we did was to produce pure hemoglobin A1c and pure hemoglobin A0. These are produced in very, very small milligram amounts, but are used to standardize the reference method. The reference method is HPLC mass spectrometry or HPLC capillary electrophoresis. Both methods give identical results and are highly accurate for measuring hemoglobin A1c. And following acceptance by all countries within the IFCC, it is now recognized as the reference procedure for standardizing hemoglobin A1c worldwide. Reference laboratories. We now have 18 laboratories worldwide using this reference measurement procedure. And when we assign calibrant values to standards, results from all the reference laboratories are used to assign these values. And because the results from all these laboratories are used, this results in a high level of accuracy. We now have a means of which we can assign values to hemoglobin A1c by all commercial methods, which are highly accurate. And traceability. We can now trace results from the patient sample through an unbroken chain of events back to the primary reference material. This means that for now and for the future, we know results will be the same and are highly accurate. And we can see this now in later CAP surveys, which show that we are now achieving the right results for our hemoglobin A1c, and the variability around that result is far tighter. And because of this, we've seen that CAP has improved their acceptance criteria from about 15% back in 1996 to plus or minus 6% now. And this can be tightened even further. So with calibration and standardization of results, how are we going to report these results worldwide? Well, in 2007, the American Diabetes Association, the European Association to Study Diabetes, the International Diabetes Federation, and the IFCC met to discuss how to report hemoglobin A1c results. And the consensus was that the IFCC reference system for hemoglobin A1c is the only valid anchor to standardize this measurement. And also hemoglobin A1c results should be reported worldwide in IFCC units, or more accurately SI units at millimoles per mole, and derived NGSP units percentages. Okay, so how are we going to use this to monitor our patients with diabetes? Well, hemoglobin A1c became important from the publication of the DCCT study, the Diabetes Control and Complications Trial in type 1 diabetics in America, where we could see that as hemoglobin A1c values increased, so did the rate of retinopathy, nephropathy, neuropathy, and microalbuminuria. And the higher the value, the greater the increase in these complications. We could also see from the UK PDS, which is in type 2 diabetics, that a 1% decrease in hemoglobin A1c, or a 10 millimole per mole decrease, resulted in a 21% decrease in the deaths related to diabetes, a 37% decrease in microvascular complications, and a 14% decrease in myocardial infarctions. So a very small improvement in hemoglobin A1c resulted in vast improvements in outcome. So what assumptions do we have to use if we're going to assume that hemoglobin A1c is a monitor of glycemia? We have to assume that hemoglobin is present at a constant concentration. We have to assume that the lifespan of the red cell is a constant. We have to assume that microenvironment is a constant. Now, this may be true in individuals, but may not be true in the population as a whole. But only if these are constant does glucose become the only variable and hemoglobin A1c represent glycemia. So what affects the hemoglobin A1c result? The lifespan of the red cell has an effect on hemoglobin A1c result. And Bob Cohen, looking at red cell lifespans, corrected values and could show that if you normalized the red cell to 120 days, you could normalize the hemoglobin A1c, showing very clearly that the lifespan of the red cell had a direct effect on hemoglobin A1c. Ethnicity affects hemoglobin A1c. We can see here data from the diabetes prevention program that showed that the mean hemoglobin A1c in subjects with impaired glucose tolerance was 5.78 for whites, 6% for Asians, and 6.18% for blacks. And this is after adjusting for anything that may affect glycemia, age, sex, blood pressure, etc. So blacks have got a higher hemoglobin A1c than whites for the same level of glycemia. Age. As we get older, hemoglobin A1c increases, and this is independent of glycemia. This is a study by David Nathan and co-workers that showed independent of the level of glucose, hemoglobin A1c levels increased decade upon decade. Anemia and its effect on hemoglobin A1c. This is a systematic review that me and a group of workers did some years ago and showed that iron deficiency anemia and iron deficiency per se clearly have an effect of increasing hemoglobin A1c values, probably because red cell survival increases with iron deficiency anemia. But there is no clear-cut point at which anemia becomes a problem. Non-iron deficiency anemia showed either no change in hemoglobin A1c or decreased values in hemoglobin A1c. And the message here is knowing the hemoglobin level alone is insufficient to judge whether the hemoglobin A1c is affected or not. Just quickly, this is a very nice but very small study done in 2004, where 50 patients with iron deficiency anemia were compared with 50 controls. The hemoglobin A1c in the healthy group was 5.9%, plus minus 0.5. In the iron deficiency anemia group, it was 7.4, plus or minus 0.8, and that was significantly different from the healthy group. This iron deficiency anemia group were just treated with iron, nothing else, just iron. And 3 months later, the hemoglobin A1c had fallen to 6.2%, which is not significantly different from the healthy group. There are a large number of people with iron deficiency anemia, and we don't know who they are, so we have to be careful. Hemoglobin A1c in diagnosis. We have already seen the large number of patients with diabetes, but probably the most worrying thing is that about 50% of people with diabetes are out in the population undiagnosed. So in 2011, the WHO recommended that hemoglobin A1c can be used for diagnosis of diabetes and set a level of 6.5% of 48 millimoles per mole as the diagnostic cut point for diabetes. But they went on to say that this level does not exclude diabetes diagnosed with glucose tests. So where 6.5 come from? Well, it came from a number of studies, the DTEC2 study mainly, which showed that as hemoglobin A1c values increased, at a level of about 6.5%, there was an inflection in which the level of retinopathy increased. Now, there's a problem here because this increase was an established retinopathy and wasn't based on things like macrovascular complications. At 6.5%, we've already got an increase in the number of patients who've shown diabetes manifestations, an increase in cardiovascular disease, an increase in stroke, and an increase in total mortality. Is 6.5%, 48 millimoles per mole, the right value, or isn't it? Where did it come from? As I said, it comes from the DTEC2 study. But if you look a bit closer, you see that the ROC curve analysis shows it should be 6.4%. So why recommend 6.5? Probably because it's an easy number to remember. So what is diabetes? Well, diabetes is a move from normal glycemia through dysglycemia into frank diabetes, with an increasing risk of cardiovascular disease and microvascular complications. And we're diagnosing diabetes at this point here, where cardiovascular disease and, more importantly, probably microvascular complications have already increased. And what we need to do is to bring this diagnosis closer. Now, these hemoglobin A1c may help this because we can screen and look for more patients who probably have the disease. Quality of results. The difference in diagnosis between diabetes and low-risk diabetes is only 7 millimoles per mole, 0.7%. Methods have to be highly accurate to achieve this. In precision, again, there's difference between diabetes and low risk. We need CVs of our methods to be about 2%. If they reach 4%, then we can overlap between these two very different risk factors. So the IFCC task force, which I chaired, came up with recommendations using sigma metrics to actually identify quality in hemoglobin A1c. And we suggested 2 sigma level of quality at 5 millimoles per mole. So we looked at a bias level of 5 millimoles per mole and a CV of 5%. Why 5 millimoles per mole? Well, this is some work from Erna Lenters that asked clinicians a question: what do you believe is a true difference in hemoglobin A1c? And they said 5 millimoles per mole they believed was a true difference in hemoglobin A1c. So we used this sigma metrics model in a large European study, looking at 2,875 laboratories throughout Europe. And we can see that most laboratories were actually coming within the sigma metrics acceptable level. The important thing to note here is that the bias is very small, showing that standardization has worked. But imprecision still leaves improvement. Between laboratory agreement of different methods has got a little way to go here, and manufacturers need to work on trying to improve this imprecision of agreement between laboratories. You can use this sigma metrics model on the CAP data. As we can see here, back in 2014, the mean overall result was outside acceptable levels. But in 2018, the mean result falls within the acceptable levels. How does this happen? Well, poor performing methods have gone and have been replaced with better performing methods. And this is how we can use quality data to move quality onwards. So just to finish, to be topical, let's look at hemoglobin A1c, diabetes, and the COVID-19. To my mind, COVID-19 and diabetes has two effects. The social aspects. We are seeing a problem with our patients now because patients are not seeking medical attention. They're not coming into clinics or hospital to have their diabetes looked at. This could have a long-term effect on the control of the patient with diabetes. And the biological effect and clinical outcome itself directly related to COVID. Even though we don't know what this effect actually is, we are seeing what it looks like in the systems. I just want to present two studies to you from UK. And from this study, we can see here of inpatient deaths from patients who have shown to be COVID positive. We can see based on patients who are non-diabetic, patients with both type 1 and type 2 diabetes throughout the age range shows an increased risk of dying in hospital based against people who are not diabetic. You can see here the odds ratio. If you're diabetic, you're far more likely to die of following infection with COVID-19. Why is this? Well, this other study looks here that diabetics, as hemoglobin A1c values increase, your risk of dying increases. And in type 1 diabetics, it becomes significant at this level. In type 2 diabetes, you can see there's a significant increase at a far lower level as well. So patients who have got diabetes, unfortunately, are at a far higher risk of dying following infection with COVID-19. So hemoglobin A1c in the future. Our improved understanding of hemoglobin A1c measurements and the better analytical methods we have these days have enabled us to look more focused on individuals and individual treatment targets. So if you look at these different conditions here, some are modifiable and others are not modifiable. But let's look a bit more closely at here. Disease duration and life expectancy. Because diabetic complications develop over time, if you got a young, newly diagnosed diabetic with a long lifespan in front of them, we want to be more stringent over their control. If you assume 7% or 53 millimoles per mole as a target for treatment, then you want to get that number lower if that patient has got a long time to live because they want to stop these complications happening. If the patient is an older individual with long-standing diabetes, you can be less stringent with them because they've got less time to develop the complications. And also, their life is probably better served by giving them a bit more freedom in what they choose to do. So we now need to review our diagnostic targets for diagnosis based on ethnicity, age, etc. Do we need different diagnostic targets for different ethnicities and different ages? We need to look at screening for diabetes in different populations. And hemoglobin A1c may have a risk factor in the non-diabetic population itself, such as cardiovascular disease. So to finish, if we look at the evolution of hemoglobin A1c in clinical practice, it started off with the discovery of a new hemoglobin fraction, recognition in clinical medicine, the publication of the DCCT and UK PDS in type 1 diabetes and type 2 diabetes, giving us a very clear understanding of hemoglobin A1c and its importance in developing complications. Standardization of the results globally using IFCC standardization. This standardization allows us to set targets for treatment and allows us to actually use hemoglobin A1c for diagnosis. And the recognition of individual variation, because we can now measure this fraction so well, has allowed us to start working towards individual treatment goals for our patients with diabetes. Just to finish, I'd just like to bring your attention to the IFCC Committee for the Education of Use of Diabetes, of biomarkers in diabetes. This is an IFCC Committee for Education in Diabetes, which I chair, and we have other members from UK, from Japan, America, and the Netherlands. And if you want to talk about diabetes, organize any educational symposia, or even if you wish some educational material, please contact us and we can help in any way we can. Thank you.
Thank you, Dr. John, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. Let's get started. Our first question is, why do you think type 2 diabetes is not commonly diagnosed in children, adolescents, and younger adults?
Well, there's probably a number of reasons for this. And part of the reasons is until recently, type 2 diabetes was typically thought as a disease of the older, middle-aged, and elderly individual. And the unrecognized etiology of the disease means it's difficult in clinically distinguishing the diabetes in children and adolescents, and the lack of guidelines when to screen children. So our understanding now of diabetes in children is changing dramatically. And also the obesity we now see in the younger individual is leading to us realizing that we can be seeing type 2 diabetics in these younger individuals.
Thank you, Dr. John. Our second question, is there a link between obesity and diabetes?
Yes, I think so. Obesity appears to be a key factor to health. It's often related to a decrease in physical activity. And we are seeing a remarkable increase in obesity across the age ranges, across all different ethnicities. The rise in type 2 diabetes rate mirrors this growth in urbanization and economic development. Overweight and obesity have become major problems in adolescents around the world. There's hardly a country in the world that is now not suffering from this pandemic of obesity.
All right, thank you. We have another question. Do you believe there's room for improvement in analytical quality?
Yes, I think so. From the slides we saw from the Euro A1c study, we have seen the standardization has resulted in overall improvement in the accuracy, with major manufacturers achieving values well within bias targets. And this has been a huge success for standardization and a huge improvement in the situation, which I'm very pleased to have been involved with. But there's improvement to be made in the between laboratory agreement of results. Imprecision has got a little way to go, and manufacturers are now working very hard to try and improve the situation. So accuracy, bias has very, very good outcome. There needs to be improvement in imprecision.
Okay, thank you again, Dr. John. Our next question. Of the 3 detection methods discussed for separation of hemoglobin A1c, charge, structure, or chemical differences, is there a preferred detection method to detect hemoglobin A1c?
I think here laboratories need to select the method they wish to use based on the quality of the method they've got, standardization of the method, and precision and accuracy of that method. Most manufactured methods that we avail to us now in the clinical laboratory are actually extremely good. But there are some methods out there which probably don't work as well as others. So you've got to decide for yourself in your particular laboratory what is right for you. The choice of detection method is less important than the quality of the result it is giving you. So you need to actually decide as a laboratory director or as a scientist within that section as to what is important to your laboratory and what's the method that gives the best results in your particular laboratory.
Okay, I've got time for one more question. Do you feel that individualized treatment plans will lead to better outcomes for patients with diabetes than trying to get everyone to below 48 millimoles per mole per 6.5% HbA1c?
Yeah, individual treatment plans will lead to better outcomes for individuals. Target values are based on population rather than individuals. For older people who are likely to have other medical issues, the goal should be to lower the hemoglobin A1c to a level which is suitable for them. Maybe it's 7%, 53 millimoles per mole, maybe it's not. And you shouldn't be aggressively treating them to lower the values down to, say, 40 millimoles per mole, 6.5%, when it possibly is causing them more harm. And by harm, I mean harm to themselves as individuals rather than harm in terms of complications. People who are older need to be given a bit more freedom of life. Whereas if you're a younger individual with a long-term to live with diabetes and the complications it might bring, you want to be a bit more stringent with them. But the thing we have learned over the last few years with diabetes is that you should be individualizing this treatment to the person themselves and not to an overall treatment goal based on population.
Thank you, Dr. John. Do you have any final comments for our audience?
I think basically hemoglobin A1c is a tool which is now standardized worldwide. We know what the limitations of the method are. We can devise guidelines for our patients, individualized to the individual patient, and we can set out diagnostic categories to identify these patients, hopefully quicker than we have done in the past, so we can get on top of this disease and control it, because there is going to be increasing numbers of patients with diabetes in the world in the coming years.
Well, thank you again, Dr. John, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.